We will discuss about classic heat stroke, also known as severe non-exertional hyperthermia. It is a frequent question in recent exams because there was significant mortality in this years of heat wave. So they might give you a direct question, the short note or long question on heat stroke, or they might give you case scenarios. There are few examples I will tell you first, and then we will discuss about heat stroke. First case scenario is 40-year male labor was found unconscious at the construction site. Frothing from mouth was observed. The core body temperature recorded in the emergency room was 106 degree Fahrenheit. Here are few clues about the heat stroke. Just construction site, there is a heat exposure. Frothing from the mouth, there was a seizure, and unconscious is altered mental sensorium, and core body temperature of 106 degrees Fahrenheit. Another case scenario is 60-year-old female living alone on the top floor of the house, which was seen apparently well till morning, was found unconscious in the evening hours by her neighbors lying in her vomiters. Taken immediately to the ER, core body temperature was 105 degree Fahrenheit. Here the clues are elderly female living alone, top floor, heat exposure, also unconscious, altered mental sensorium, vomiting, and core body temperature. Next case scenario is 56-year-old female from South India who came to Delhi, got unconscious on a tourist bus during her visit to the monuments in the afternoon after complaining of lethargy and vomiting. The core body temperature recorded in ER was 105 degree Fahrenheit. Here is an elderly female. There is a lack of acclimatization. She came from South India on a tourist bus, like during her visit to the monuments. She was outside in the heat. There is a complaint of lethargy and vomiting. That is the symptoms of initial symptoms of the heat stroke, followed by core body temperature of 105 degree Fahrenheit. All these three are the real life case scenarios from the emergency room of our hospital. Now, what is the definition of heat stroke? Heat stroke definition consists of four components. Number one component is elevated core body temperature of more than 40.5 degrees Celsius or 100.105 degree Fahrenheit to be measured in rectum or esophagus. In all three case scenarios, the temperature was recorded in 105, 106. Second point is central nervous system dysfunction should be there. Anything such as altered mental sensorium, irritability, drowsiness, coma, anything can be there. Exposure to severe environmental heat load that cannot be dissipated. In first case scenario, it was construction site. Second case scenario, it was top floor building. Then in third was she was roaming around in a bus. Lack of alternative explanation for hyperthermia. There should not be anything else that can explain the temperature of more than 106 or 105 degree Fahrenheit. It is a severe illness with associated mortality of 21 to 63%. Now the risk factor, the extremes of ages. In our case, the 60-year female, 56-year female, or there might be children or infants. Pregnancy, one another case scenario where a 30-year female patient who was 5 months pregnant came to the hospital. She got unconscious on her way. She was found outside. So they can also go into heat stroke. They are more prone for heat stroke. Obesity, poor physical condition, lack of acclimatization. As in our third case scenario, the patient visiting from South India to North India in the Delhi's heat, lack of air conditioning on the top floor, social isolation, the patients living alone, dehydration, diabetes, cardiovascular disease, heavy alcohol use are another risk factors. Some medications and illicit drugs that can increase core body temperature, such as diuretics, anticholinergic drugs, sympathomimetics, salicylates, antiepileptic, and topiramate. Now, the symptoms of the heat stroke, weakness, lethargy, nausea, dizziness, vomiting are the initial symptoms of the heat stroke. When a person is exposed for excessive heat, initially he will complain of weakness, followed by lethargy, then he will complain of nausea, vomiting, dizziness. Now the CNS symptoms start, such as slurring of speech, followed by irritability, inappropriate behavior will be there, agitation, delirium. All these are a component of the altered mental sensorium. Followed seizures can be there, followed by coma, depending on the severity of illness and severity of heat exposure. Now the signs of heat stroke. You after taking thorough history of the patient, what happened, you will look for the patient. You will examine the patient. There will be tachycardia. The pulse rate will be more than 100. Tachypnea, patient will be having respiratory distress. White pulse pressure, hypotension, blood pressure will be low. There will be flushing due to cutaneous vasodilation. The face might be red. On respiratory system examination, when you put the stethoscope on the chest, there will be crackles due to non-cardiogenic pulmonary edema. Bleeding manifestations might be there. There might be blood in vomitus due to coagulopathy. Oliguria, when you insert Folies, there might not be any urine in there because of the oliguria. Skin can be dried or moist. Dehydration can be there, cannot be there. It is not a prerequisite for a heat stroke. Now, the investigations. After taking thorough history and after doing proper examination of the patient, we will investigate the patient. What are the lab derangement that can be there which supports our diagnosis of heat stroke? Number first, any patient who is brought to you in emergency in unconscious state, the first and foremost investigation is blood sugars. You will look for the blood sugars with the help of glucometer present in your emergency, and you will correct it if there is an hypoglycemia. Second is arterial blood gas. You will send ABG. It just take 10 to 15 minutes for an ABG reports to come. There might be metabolic acidosis because of increased lactate level, and the respiratory alkalosis because of respiratory distress. Patient will be tachypneic and CO2 will be washed out. And because of the CO2 washout, there will be respiratory alkalosis. Complete blood count. There might be leukocytosis. WBCs may increase up to 30 to 40,000 per millimeter cube, and there might be thrombocytopenia. Liver function tests, SGOT, PT are rarely normal in patients of heat stroke. Let's suppose a patient came to you after taking thorough history, physical examination, and few ABG and RBS. You made a differential diagnosis of heat stroke. Now you receive a report that LFT are deranged. That goes in favor of heat stroke. Coagulation profile may be deranged because of the coagulopathy due to liver injury and DIC. Troponin I and troponin T may be elevated because of the heat stress, heat related myocardial injury. Serum electrolytes, there might be hypocalcemia, hyperphosphatemia because of rhabdomyolysis. Kidney function test might be deranged because of the acute kidney injury. When you send urine for analysis, there might be protein, blood, tubular cast, and increased specific gravity. They all indicate kidney injuries. Serum creatine kinase, LDH, and urine myoglobin levels may be increased because of the rhabdomyolysis. Now, further examination, chest X-ray, we will get to look for the pulmonary edema. As in physical examination, we were looking for the crackles in chest examination. ECG, there might be arrhythmias, conduction disturbances, heat-related myocardial ischemia or infarction. There might be non-specific STD changes. NCCT had to rule out CVA. As any unconscious patient, the CVA need to be ruled out. Any infarct, any hemorrhagic stroke need to be ruled out for unconscious patient brought to you in emergency. CSF studies to rule out other causes of altered sensorium, as fever might be there in bacterial meningitis also. Bacterial meningitis also takes only around 1 or 2 days to manifest as seizure, coma, altered mental sensorium, and there might be a fever of 105 or 106 degree Fahrenheit. So other causes of altered mental sensorium with fever need to be ruled out. So we do CSF studies. We will send for gram stain culture, cyto, and biochemical studies to rule out infections, meningitis, meningoencephalitis. Toxicological screening for drugs that may contribute to hyperthermia, such as ethanol, amphetamines, cocaine, salicylates, hallucinogens, and lithium, should be done. Now, the management of heat stroke. Any unconscious patient brought to you in emergency, you will do ABCD thing. Air for A, airway, intubate if required. When the airway is not patent, if the patient's GCS is 8 or less than 8, you will intubate the patient. Second is breathing. The patient is tachypneic, hypoxic, you will provide the supplemental oxygen for the patient. Third is circulation, in which if the patient is hypotensive, you will do the fluid resuscitation. That means normal saline 20 ml per kg of body weight, IV bolus is to be given. If the patient is still hypotensive, you will give norepinephrine or epinephrine dobutamine. Norepinephrine is preferred over epinephrine and dobutamine. But this is given after the cooling measures have been done. Like you brought down the body temperature patient and you have done the fluid resuscitation. Then still patient is hypotensive, you will start the epinephrine or norepinephrine. Because alpha adrenergic agonists, they cause vasoconstriction, and vasoconstriction decrease the heat dissipation. So first dissipate the heat and then start the inotropic agents. Antipyretics such as paracetamol and aspirin, there is no role, they are not required. And they might be detrimental for the patient because they might exacerbate the hepatic injury or DIC. Salicylate can contribute to the hyperthermia by uncoupling oxidative phosphorylation. Rapid cooling with continuous core temperature monitoring is done. The preferred method for rapid cooling in non-exertional type of heat stroke is evaporative and convective cooling. What does that mean? We use both methods, evaporation as well as convective method. Evaporation with the help of when the mist of lukewarm water is sprayed over a naked patient, the water will evaporate and cool down the patient's body temperature. Also, fans are used to blow the air. That help in the convection of that air around the patient. So evaporation as well as convective method is used to rapid for the rapid cooling of the patient. The target temperature achieved is 100.4 degree Fahrenheit to 102.2 degree Fahrenheit. That's the target temperature that has to be achieved within 30 minutes to 1 hour. And the patient is brought down in emergency. And the core body temperature to be recorded every 15 minutes until the temperatures to be brought down below 102 degree Fahrenheit. Cooled oxygen, cooling blanket, and cold IV fluids may be helpful adjunct. These are the helpful adjunct, not the mainstay of the treatment. Such as you are providing supplemental oxygen, just provide the cool oxygen. When you're giving IV fluid in fluid resuscitation, you provide the cold IV fluid. They will help to bring down the temperature, but they're not the main method of cooling down the body temperature. Applying oil spikes to the axilla, neck, and groin is effective as an adjunct cooling technique. But when the patient is awake, he will not tolerate these things. Like nobody, no awake patient will tolerate an ice pack around the axilla, neck, and groins. Now the complications of heat stroke. Number one is hypoglycemia. We will manage it with dextrose infusion. Seizures will be managed with short-acting benzodiazepines such as midazolam with rapid cooling. You brought down the temperature, the seizures will stop. Acute decompensated heart failure managed with drugs as well as intake output charting. DIC with PRP and FFP transfusion based on the platelet count and INR values. If there is an acute kidney injury, we will do hemodialysis. In acute liver failure, the last modality is liver transplant. Rhabdomyolysis, ARDS. For ARDS, we will provide ventilatory support for the patient. Other pulmonary complications such as aspiration, bronchospasm, non-cardiogenic pulmonary edema, pneumonitis, pulmonary infarction, and pulmonary hemorrhage can be there. Long-term sequelae of heat strokes are high risk for myocardial infarction, ischemic stroke, and chronic kidney injury. Functional and neurological impairment can also be there in future for the patients who have recovered from the heat stroke. Now the differential diagnosis of hyperthermia. As initially in the definition of heat stroke, there was one line as other causes of hyperthermia has to be ruled out. The one cause of hyperthermia is environmental, high temperature that we have discussed heat stroke. Other causes of hyperthermia are infections such as sepsis, meningitis, encephalitis, brain abscess, tetanus, typhoid fever, malaria. For meningitis, encephalitis, brain abscess, we do the neurological imaging and CSF studies. For tetanus, typhoid, malaria, tetanus is a clinical diagnosis. Typhoid and malaria, we will send for investigation. Drug or toxin related, such as malignant hyperthermia, neuroleptic malignant syndrome. There will be history of drug intake. Neurological causes such as hypothalamic stroke, cerebral hemorrhages can be picked up in NCCT head. Status epilepticus, when you brought down the temperature of the patient, the seizures does not stop. We will label the patient as status epilepticus. And endocrine causes such as thyroid storm, pheochromocytoma, and diabetic ketoacidosis can also present in hyperthermia state, but there might be history of thyroid illness or diabetes. Oncological cases such as lymphoma and leukemia can also present as hyperthermia.